present in here in the urine. What it does is macula densa would see the concentration of the sodium. Depending upon that concentration of the sodium, it would decide to release what? I'm sorry. It would decide to release prostaglandins. It would release prostaglandins. Those prostaglandins, very important concept. These prostaglandins would act. So let's say PGE2. This PGE2, I hope you can see it well, I hope the camera is showing it to you. This PGE2 would then act on these pericytes and cause the release of renin, and once again this cycle would start. Once again this cycle would start. So macula densa and pericyte together worked to finally release renin, and that renin would increase the angiotensin 2, and that angiotensin 2 would cause a lot of, it acts on the it acts as a vasoconstrictor, so that would increase the blood pressure. It acts on the pituitary to release the adrenocorticotropic hormone, which then works on the suprarenal glands, which would release aldosterone. Aldosterone would go to the kidney and act on the kidney to reabsorb sodium. That sodium reabsorption would increase water reabsorption. Remember, sodium and water are friends. Just like over here, kidney and lungs were friends, sodium and water are friends. Wherever sodium goes, water goes with that. So when the water increases, the blood volume would increase, blood pressure would increase, and so we will start normalizing. Macula densa is clever. What that is doing is, as soon as it senses that there is an issue with the osmolality, it releases prostaglandins. Prostaglandins act on the pericytes, and they would cause the same cycle. One more thing, that this prostaglandin also acts, and again I know I'm making a mess over here, but I hope you can see it. This also acts on the efferent arteriole and cause it acts on the afferent arteriole. Why did I say efferent arteriole? This is wrong. Scratch that. This is wrong. I'm known to make mistakes. So the prostaglandin would act on afferent arteriole and dilate them. Dilates the afferent arteriole. So within this system, you are seeing one chemical substance which is increasing the flow and the volume of the fluid coming in by dilating the afferent arterioles. Then you are seeing the other chemical substance which is restricting the exit of the flow and increasing the GFR. We'll talk about GFR as well. So this is a function of the macula densa and the this is called juxtaglomerular apparatus. This apparatus, again, if I go back here, osmolality regulation and blood pressure regulation is done by this, and we just explained how that happens. So I would like to just very quickly go through the last few functions, which are hormone secretions, and then close this lecture and then continue again for the hemodynamics. So the hormonal secretions. Do you know that, and I'm sure that you know, if you've done the blood system, you know that kidneys produce erythropoietin. And when do they produce erythropoietin? In the hypoxic situations. If for some reason a patient is exposed to hypoxic situation, that might be because the lungs are abnormal, that might be because there is less oxygen, that might be because there is problem with the hemoglobin, that might be because there is a problem with the blood volume, and so on. There are so many reasons that hypoxia can occur. But whenever the hypoxia is prevalent, the endothelial cells, now do not forget this, write it down somewhere please, endothelial cells of peritubular capillaries. What are those capillaries? So if you come back to this board, these capillaries, the peritubular capillaries, or if I come here, these capillaries, after the efferent arteriole, the capillaries which are around the tubules, the peritubular capillaries, these capillaries, the endothelial cells of these capillaries, these cells secrete the erythropoietin. Erythropoietin, of course, goes and acts on the bone marrow and causes the release of more RBCs to combat the effect of carbon dioxide. Just remember, it's not a very fast process, it takes some days, but that is a process. So that is a hormonal action of the kidney, it's acting as a gland. Then Renin, we just talked about it. Renin is released from the pericytes. Then prostaglandins, we talked about that as well. Macula densa releases prostaglandins. Then calcitriol activation or active vitamin D. So what happens is, and this is again very important, write it down, underline it, proximal collecting duct, proximal tubule. Why do I call it collecting duct? So proximal tubular cells, these cells here, they have gotten enzymes which act on vitamin D, inactive vitamin D, and make it active vitamin D. So you know vitamin D is very important for many of our calcium and phosphate related functions. So vitamin D conversion or activation occurs in the kidney. Erythropoietin generation is occurring in the kidney. Renin generation is occurring in the kidney. Prostaglandin generation is occurring in the kidney. So kidney is doing a lot of activity which is hormonal as well. And one little tip here, the NSAIDs, non-steroidal anti-inflammatory drugs like aspirins, do you know that these can cause acute renal failure? Why do these cause acute renal failure? The reason for that is NSAIDs block the prostaglandins from the kidney. So this prostaglandin, remember the prostaglandin coming from the macula densa? This prostaglandin release can be blocked by the NSAIDs. So for example, if a patient is taking aspirin, that patient's prostaglandin release would be reduced. When that is reduced or blocked, what would happen is afferent arteriolar dilatation will not occur. Very important. You have to know this one. Afferent arterial dilatation will not occur. That would reduce the blood flow, that would reduce the blood pressure, that would cause the glomerular filtration to go down. That can cause acute renal failure. So remember this, don't forget that. And let's see what we got next. Functional unit, we talked about the nephron. The only thing here about the nephron, the cortical and medullary unit, we'll talk about it later. I believe we are good for the time being. So let's have a wrap at this point, and we will continue with the fluid hemodynamics in the glomerulus, in the peritubular capillaries. And this is something which I have a complaint here with my students, that sometimes they focus a lot at the glomerulus and they talk about hemodynamics here, what is the osmotic pressure and what is the hydrostatic pressure, but they forget about the peritubular capillaries. Guys, do not forget about peritubular capillaries. Do you know why? We filter the fluids here and we reabsorb them into the peritubular capillaries. If you do not take care of the understanding of the pressures here or hemodynamics here, then you leave half of the function of the blood system here is gone. And what happens then is this question in the USMLE or the actual patients, you sometimes then fail to understand why a particular activity or particular effect is coming. So remember, hemodynamics in the glomerulus are not just important, very important, but in addition peritubular hemodynamics are very important as well. So that is a complete interesting topic. We'll take it up later. At this time we'll wrap it up here. Thank you very much.